for the introduction. Okay. Yeah, so it's a pleasure to be here. Nice to see lots of familiar names in the list of viewers. So I'm glad to share this work that I'm presenting today. It's in collaboration with Martin Kolk, who's a collaborator, long-term collaborator of mine here at Stockholm University. And this is also co-authored with Øystein Gravdal, who's at the Norwegian Institute of Public Health and Oslo University as well. And I'll just say that this work is in progress at the moment, but it's sort of medium level in progress, I guess, because we've submitted it to a journal. We're waiting for the first reviews. So yeah, any comments will be very welcome. So let me just get started. So as Sarah said, this is about birth spacing and the health of mothers and fathers. And so I'm not going to show too many of these infographics. So and I'm not sure how helpful they are, but I hope it'll be useful to some extent. But just the point of what we're doing here is that we want to look at birth spacing between kids, but not how that affects the health outcomes of the children. Specifically, we want to look at how it affects the health outcomes of mothers and fathers. So I just want to put that clarification there, just because I've been doing quite a lot of work on how birth spacing might be related to outcomes, both socioeconomic as well as health related for the kids. So just to clarify that we're looking at the parents here very specifically. So in today's presentation, I'm going to be talking about how, as I've said, birth spacing affects parental health outcomes. I put that asterisk there just because, of course, health can be defined in lots of different ways. The way we're operationalizing it for this study is we're looking at consultations with a general practitioner, and we're going to look at two broad categories of consultations for physical health issues and for mental health issues. So this analysis will be based on Norwegian register data, and I'm going to be showing you the results of analyses based on men and women. We're going to look at short and long-term effects, potential effects of birth spacing on parental health outcomes. So I'll talk a bit more about those details later. And we're going to try and do our best to try and isolate the net effect of spacing on parental health outcomes by using two different types of models. We're going to be using individual fixed effects, where we compare an individual to themselves, like how do their visits to a doctor differ after birth intervals of different lengths. So we'll do that separately for men and women for short-term outcomes. And we're also going to look at long-term outcomes where we use sibling-fixed effects to hold constant shared family background factors shared by siblings. So that's going to be less effective, I think, at isolating the net effect of birth spacing on parental health outcomes, but you can think about it as sort of a more effective way of controlling for shared family background factors than maybe just controlling for observables. But I'll say some more about this later. So a bit on motivation. There's a large and still growing literature that examines how birth spacing is influencing the potentially influencing the health of children, but also parents. And this covers a wide range of disciplines, including medicine and epidemiology, gynecology and obstetrics, but also, of course, in the social sciences and demography, sociology, economics as well. So part of the motivation for what we're doing in this study is that although there has been quite a lot of work on this topic, a lot of it has been actually in low and middle income countries. So there's relatively less work in high income countries. Most of this work also focuses on mothers, quite naturally to a certain extent, but I think it's also quite interesting to look at whether there are any patterns of association for fathers. And this is also important thinking about potential mechanisms, right? Is any association between birth spacing and parental health outcomes driven by physiological effects of pregnancy and child delivery, or is it related to maybe stress or anxiety or, within family social factors that could also affect the health of fathers, of course. And most previous work also relies on controlling for observables. Of course, this is important and it's good, but relatively little work has tried to use the approaches that I was mentioning on the previous slide, using like individual fixed effects to try and isolate the net effect of, say, this kind of childbearing behavior on health outcomes for the parents. So we hope to try and get at a sort of more causal effect of birth spacing on parental outcomes, even though, I don't want to go too far in claiming that we managed to do that. Then there will be caveats and limitations to that I'll talk about later as well, of course. I also want to mention that there's a lot of policy relevance for this question. I think it's fair to say, for instance, the WHO recommends that women should wait at least 24 months before getting pregnant again after their previous childbirth, and in order to reduce the risk of adverse maternal, perinatal, and infant outcomes. Most of that advice is primarily directed towards mothers in low and middle income countries where prenatal care might not be as good and where medical facilities aren't as widespread or accessible. But even in high income countries, there are often recommendations. For instance, the American College of Obstetricians and Gynecologists recommends that women wait at least 6 months before getting pregnant again after the previous childbirth. But an interesting aside in the research that I've been reading is women can often, they don't seem to recall being advised about spacing behavior. So if this is important, then maybe this is something that for maternal and paternal health outcomes, maybe this is something that parents should be getting clearer advice about. I can also say something policy relevant specific for a neighboring Nordic country of Norway. So I'm working in Sweden at Stockholm University, as Sarah said at the beginning. In Sweden, there was a particular reform that was introduced in the 1980s related to parental leave compensation. And it's not directly relevant for this study, so I don't want to go into too much detail, but the idea was basically that if you had birth intervals shorter than initially 24 months and then later extended to 30 months, then the parental leave benefit that you got after your second child or the subsequent child would be based on your labor market income before the birth of your first child, rather than the labor market income that you had between the two births, which gave an incentive to have shorter birth intervals because most parents were less active in the labor market after the first birth. So there was an incentive there which encouraged shorter birth spacing, which showed up a little bit in the actual data. So this is the median interval between first and second births. It's not a totally clear pattern here because it sort of returns, it increases again later. But I think it's good to know that in general, experiments and policy interventions, whether they were deliberate or in some cases inadvertent, like this one, they can have a material impact on birth intervals. So it's important to be aware of the potential consequences of influencing the length of spacing between children, I think, both for parents and children. So I'm going to say a little bit about previous research, both in terms of short-term outcomes as well as long-term outcomes. And then I'll say a bit more about potential mechanisms that might link birth spacing to parental health outcomes as well, before I come to our study, that the actual data and the analysis that I'm presenting today. So let me just say a bit first about something that we're not actually looking at directly, but that's obviously extremely important if you want to understand how birth spacing might affect maternal health outcomes in particular. And so that's that there is a lot of research on how birth spacing might affect birth outcomes for mothers. So systematic reviews suggest that particularly short and long intervals seem to be associated with an increased risk of a variety of negative outcomes, including uterine rupture, uteroplacental bleeding, preeclampsia, abnormal labor experiences, and also obesity and gestational diabetes. So this is pretty consistent across a wide range of studies. And what you tend to find is a kind of J-shaped curve where basically, outcomes after particularly short birth intervals, which is defined differently across different studies, not particularly helpfully. But, in some cases that's shorter than, or, just 9 months, or in some cases it's less than 2 years between the births. But shorter birth intervals and long birth intervals seems to be associated with worse outcomes, birth outcomes. Most of that research, though, has relied on controlling for observable factors. So, yep, very reasonable observable factors, but maybe not necessarily capturing unobserved factors that might drive an association between birth spacing behavior and adverse birth outcomes. And so this is kind of be sort of a recurring theme of this presentation, as it probably should be in all social science research, but I just want to highlight that it's very important to think about selection and confounding when thinking about birth spacing behavior, because birth spacing is not randomly distributed across families, of course. So there's a variety of papers out there that indicate that particularly short and also long birth intervals are more common amongst sort of families that are less socioeconomically advantaged, for instance, or more common amongst teenage parents. Short birth intervals are more likely to be unplanned births, for instance. I'll say a bit more about this later. So two papers that we're aware of that actually looked at individual fixed effects to look at how birth spacing might be associated with outcomes from others are two papers by, well, a paper by Hanley and colleagues and Liu and colleagues, respectively, using data from Canada and California. State level data, I think, from British Columbia and California. And so they used the kind of within mother comparison and looked at the variety of different outcomes. And Hanley and colleagues found that short birth intervals, even after you did this mother fixed effects, short birth intervals were associated with an increased risk of gestational diabetes and obesity. And Liu et al., they looked at an outcome which they called severe maternal morbidity, which encompassed a number of different outcomes, including eclampsia and sepsis. And they found some slightly surprising findings where short birth intervals were actually associated with a lower risk of these of severe maternal morbidity, whereas long birth intervals were associated with an increased risk of severe maternal morbidity. So some kind of inconsistent and surprising findings there in these two studies. So there's certainly space for more work on this topic, I think. I just want to mention that there are a variety of studies that have looked, some by me and colleagues, that have looked at how birth spacing affects child outcomes. And we found in this work that a lot of this seems to be, these negative effects of birth spacing seem to be explained by selection. So when you control for unobserved parental characteristics, family characteristics, that seems to explain away a lot of the negative effects of birth spacing. And we've done this for, I just want to talk about this because I think it's really important for the selection story, even though it's not directly related to the parents' health outcomes necessarily. But we've looked at a variety of different outcomes, educational and socioeconomic, using population register data from Sweden, but also state level register data equivalent to the register data in the US from Utah. And I'm happy to talk more about that if people are curious about that data source, but it's very good quality, even though it's a particular context that should be considered. So we've looked at educational and labor market outcomes across the life course and also health outcomes at different stages in the life course. And an overall sort of representative finding that we have, I hope you can see my mouse, but if you look at here, this is the x-axis. On the x-axis, we've got birth intervals going from particularly short ones up to longer ones. And then in this case, these are the results for years of education. And so this is the length of the preceding birth interval in the left panel, and this is the length of the following birth interval from the child's perspective in the right panel. And basically, you see, if you look at this red plot, this J-shaped curve is the results when you don't hold constant all sort of unobserved family background characteristics, and you see this characteristic J-shaped curve where kids born after very short birth intervals or very long birth intervals have worse outcomes. But when we do the sibling-fixed effects analysis, we wipe out most of this negative effect of birth spacing. And this is true when you look at the subsequent birth interval as well. So this is for Sweden for years of education, but it's remarkably consistent across a variety of different outcomes in Sweden. It's a bit noisier in some analyses than others, but yeah, that's how it goes. And these are results from Utah. where in this case, the orange line, the orange plot line is the sibling-fixed effects model. So we find very similar results in Utah as well. So selection is probably potentially a very important part of this story. But as I said before, we're not actually looking at adverse birth outcomes in our study. We're looking at GP consultations for physical health problems and mental health problems. So let me just say a bit about research on non-adverse birth outcomes. So let's say mental health outcomes. As far as we're aware, little research has been done on the relationship between birth spacing and parental mental health. The small amount of research that we could find, so a couple of studies looking at birth spacing, and we also considered research that looked at having twins, which you might think of as a kind of particular, a special case, but a case where you have two exceedingly closely spaced children, you could say. And it seems that having twins and having particularly short birth intervals seems to be associated with an increased risk of depression, anxiety, postpartum depression, and even an increased risk of outcomes like parental divorce. So obviously, this indicates that short birth spacing may indeed sort of have some negative influence on parental mental health outcomes. There's also a large body of literature, again, challenged a bit by this fixed effect approach, but nevertheless, I think very short birth intervals do seem, my reading of literature is that extremely short birth intervals seem to be associated with an increased risk of preterm birth and low birth weight. And both of those things, having a preterm birth from the parent's perspective or having a low birth weight delivery, those are also associated with an increased probability of depression and anxiety for the parents. This is a bit complicated, of course, because antenatal depression and anxiety can also increase the risk of preterm delivery and decrease the likelihood of breastfeeding, which in turn can impact birth spacing. So it's all it can get a bit complicated as you start to look at this question and think about it more carefully. But yes, just to let you know about what is available in the literature on this particular outcome. If you're thinking about research on long-term outcomes, which we also do in this paper, there isn't very much in this space either, particularly in high-income countries. So there's some work, including by Øystein Gravdal, one of my co-authors on this paper, also Emily Grundy, much of which they've done together, that finds that short birth interval seems to be associated with higher mortality in later adulthood for both mothers and fathers, both all-cause mortality as well as cardiovascular mortality. And there's some, not that much, but there's some research that indicates that short birth intervals can be associated with higher, different types of morbidity, like an increased risk of cardiovascular disease. So let me say some things about the mechanism. So, I've talked a bit about the previous research that indicates that birth spacing is indeed associated, short birth intervals and long birth intervals are indeed associated with worse health outcomes for mothers and fathers. But like how are these things actually connected potentially? So there are clear potential physiological processes that might link birth interval length to maternal health outcomes. So maternal nutrient depletion, for instance, there's actually a variety of different adverse birth outcomes that might be associated with both short, medium, and even long-term negative health outcomes for mothers. But maybe the most serious amongst these is preeclampsia, and that's been shown to have long-term sequelae that can result in increased risk of chronic hypertension and ischemic heart disease, as well as diabetes and a variety of other negative outcomes. So short birth intervals are associated with an increased risk of preeclampsia, and this in turn can have long-term consequences. As you might suspect, there are no direct physiological pathways linking birth spacing to health outcomes for fathers. So if there's anything for fathers at all, it's more likely to be related to kind of social processes, the stress of raising closely spaced children, perhaps, for instance, or selection processes as well. So let's talk a bit about these. I mean, there's some research that shows that spacing between children can impact parental time and attention. And so, so it can affect parental stress and anxiety potentially. This might be worse if child rearing is combined with full-time employment in particular. We know that mothers take on, usually they're taking on a double shift, or this is at least more common. It's even more, even in countries like Norway or Sweden, where there is relatively better gender equality, a more equal share of these kind of responsibilities in empirical data. It's still often the mother who takes on more of these responsibilities, of course, and just overall prolonged stress and insufficient rest tends to be bad for your health. But let me just emphasize again the potential importance of selection processes, just because I think it really is exceedingly important when we think about this question. As I said before, birth spacing is not randomly distributed across families. I mentioned before, short intervals are found more likely to be found amongst disadvantaged parents. You might also think about health dimensions to this. For example, if you are having trouble getting pregnant, either related to maternal aspects of this question or paternal aspects, if that is related to some kind of underlying health dimension, you might find that, parental health problems are actually associated with longer birth intervals because it's taking longer to get pregnant again. And that kind of confounding could be part of an association between birth spacing and health outcomes for parents. As I said before, short birth intervals are associated with unplanned births. We might also think about the fact that long birth intervals could be more likely to result from family complexity, so partner change. That could lead to longer spacing between childbirths, and this might also, there's some research that suggests this might be related to parental health outcomes as well. Though of course there's selection in that kind of research question as well. And as I said before, many studies have controlled for observable, but it's often difficult to capture all the confounding factors. They might not be measured at all, even though some of them probably are, or maybe imperfectly. And so, so that's part of the motive for the strategy that we're taking in our paper. So let me just get on to what we've been doing so far. So we're using Norwegian population register data. We have data for mothers and fathers. They should be born in 1935 or later. And we look at parents who had at least one live birth from 1996 to 2017. This varies a bit depending on the type of analysis that we're using. So as I'll say, or clarify in a couple of slides, when we do our individual fixed effects comparison, for instance, where we're looking at outcomes for parents after birth intervals of different lengths, they need to have had at least 3 children. No, of course, this is going to affect our external validity and the degree to which we can generalize that results. But of course, if we want to compare birth intervals of different lengths between parents, then they need to have had at least 2 birth intervals, right? So for that reason, we need to condition on them having had at least 3 kids. It's a bit different when we look at the sibling-fixed effects analyses. So we look at outcomes after parities 2 to 5. We exclude parents who had any kind of twin delivery because we don't want to mix up the effects of a twin birth or other kind of plural birth, triplets, etc., with any effects of birth spacing. So, as I said before, the outcome variables that we're looking at are GP consultations. We look at the annual number of face-to-face GP consultations over the period 2006 to 2018 for mental diseases, or consultations for things that can be classified as sort of mental health problems, and for physical health issues as well. But we exclude those outcomes that are explicitly pregnancy related. So we're trying to look at sort of non-adverse birth outcome related health issues. It's important to mention that these different health measures reflect a combination of severe and less severe conditions, because access to, so GPs are they're the primary care source, and so access to sort of more specialized consultants flows through them. So some of these visits are, for less severe things, and some are for more severe, of course. So we look at two types of short-term. So we look at health outcomes in two short-term periods, 1 to 5 months after the birth, as well as 6 to 11 months after the birth. And the long-term outcomes that we look at are 10 to 11 years after the last childbirth. I'll say a bit about that more in a couple of slides. So these short-term outcomes, we want to avoid picking up adverse birth outcome related issues. So that's why we don't look at things in the first month. But we also, we'd look at these two different ones because we also don't want our health outcomes to be measuring health related to a subsequent pregnancy. So we think it's extremely unlikely, and it's empirically extremely uncommon to have had a second pregnancy starting within 5 months of your last childbirth. And so we're confident that when we're looking at health outcomes once 5 months after birth, we're not picking up new pregnancy related health issues. That's still going to be uncommon in the period 6 to 11 months after birth, but it's possible. We control for some different factors in addition to the fixed effect modeling that we do. This varies a little bit by model, but we control for things like parental age at the time of birth and parity. And we control for some socioeconomic and partner relation factors as well. So educational level, marital and cohabitation status, and also whether the co-parent is the same parent as at the previous childbirth. So just 2 slides with my infographic. So in our individual fixed effects models, we're looking at, as I said before, we're looking at how outcomes after birth intervals of different lengths are associated with the number of annual GP consultations. And we do this separately for men and women. And we're going to run 3 different models for each of our short-term outcomes. So that's 6 in total for the 1 to 5 month period after birth, and then for the 6 to 11 month period after birth. So 1A, 1B, and 1C is for the period 1 to 5 months after birth, and 2A, 2B, and 2C is for the period 6 to 11 months after birth. For 1A and 2A, we're going to use linear regression on like the full population of parents that we have for those, the full population of people who had that many children, basically, 3 children at least. And so we control for parental age and parity. But in our linear regression model, 2B and 2C, 1B and 1C, we introduce some additional controls. But more importantly, we use our fixed effect sample. So we compare, mothers to themselves and fathers to themselves after birth intervals of different lengths. And in the final model, we introduce some additional control variables here for parental SES and partnership status. When we do our sibling fixed effects analysis, it's a little bit more complicated in some ways. So what we do is we look at brothers, for instance. We look at the mean birth interval that they've experienced, and we define brothers as people who have a shared mother. And then 10 to 11 years after their last childbirth, we look at the number of annual GP consultations that they have for physical health issues and mental health issues. So this is our way of trying to have a more effective control for shared family background factors that might drive some kind of association between childbearing behavior, so birth spacing behavior, and these health outcomes. Okay, so I think part of the advantage of this is just that there's a lot of unobserved family background factors that we don't necessarily measure or control, can capture specifically. Maybe, I mean, there's shared genetic factors, there's maybe underlying health factors that don't become apparent until people get a lot older in some cases. And so to the extent that those might be shared by siblings, this might be a more effective way of controlling for those things. So we do this separately for brothers. we do it separately for brothers, comparing them to their brothers, and we do it separately for women, comparing them to their sisters. And so, yeah, we have these three models here. So we have a full sample, and then we introduce the sibling-fixed effects for the population for which we can link people to their siblings. Let me show you, I'm going to show you a few slides with descriptive results. These are the number of annual GP consultations for mental health issues 1 to 5 months after birth for women in red and men in blue. This is the length of the birth interval on the x-axis, the average number of GP consultations. You can see this is, in absolute terms, it's not very much, so not very many, but you can see that there is this. So this is just completely unconditional, right? This is just the average, the mean in each of these groups for men and women, and so, but you do see this kind of U-shaped curve here, where there are more consultations for mental health issues for people, men and women who had very short birth intervals or longer ones. If we look at the period 6 to 11 months after birth, the scale changes a little. I'm going to show you a graph in a minute where we could put all these side by side so you can see how the scale lines up with each other. But yes, you can see this kind of same U or maybe J-shaped curve here. Depends how you turn your head a little bit. But those who have these sort of birth intervals of 2 to 3 years in the middle, they seem to have the fewest number, just unconditionally. Same pattern here. If we look at annual number of GP consultations 10 to 11 years after birth, but they are on an absolute scale, they're more common. And these are the number of consultations for physical health outcomes. So it seems to be more common after particularly short birth intervals. It's more common for women in general across these graphs, you'll have noticed as well, but something like, something like this. And this is for the period 6 to 11 months after birth, and this is for the period 10 to 11 years after birth. So if we just put these side by side, here it looks relatively flat, but zoomed in, you could see that there was more of a sort of a U-shaped curve in each of these descriptive plots, but you can see that these number of annual GP consultations, it's much more common 10 to 11 years after childbearing. So of course, that's partly just because they're a lot older, right? So, or significantly older, and so yeah. These are the same patterns for number of annual GP consultations for physical issues. And so you'll notice, of course, that the scale is much larger for these physical health issues, going up to sort of 5 annual consultations a year, whereas for visits for mental health issues, it only goes up to about an average of 1 per year at the very most. Okay, so let me show you some results from the regression output. Okay, so let me just walk you through this slide because I know that there's a lot going on here. So on the y-axis, we've got the number of GP consultations 1 to 5 months after birth. On the x-axis, we've got the length of the birth interval. So the shortest are 6 to 11 months, up to 120 plus, so 10 years. And then 4 different panels, right? Each of which contain the results from 3 different regression analyses. So here, these first 2, we've got the results for mental health, number of GP consultations for mental health issues, first for mothers, then for fathers, and then these are for number of annual GP consultations for physical health issues for mothers and then fathers. So the blue lines are, so basically the blue lines are the ones without fixed effects, and the red lines are the ones that include the individual fixed effects. So holding stable, constant individual factors, constant. So these blue estimates here, the reference category is of having had a birth interval of 24 to 29 months So that's here. That's the same across all of these. So these are all separate regression analyses, just plotted on the same graph, so you can compare them side by side, not an interaction or anything. So these blue plot lines show something akin to what I showed you in those descriptive plots, I would say. So mothers and fathers who have particularly short birth intervals or particularly long birth intervals, they seem to be visiting the doctor more often. But, you know, even if these results are statistically significant, just because we have hundreds of thousands of observations, because we have this Norwegian population data, in absolute terms, these are actually, you know, these are still rather small differences, right? So it's like 0.05 visits to a doctor more per year, and once 5 months after birth. And when we introduce the individual fixed effects analysis, we basically wipe out even this kind of small negative effect of very short or very long birth spacing. So based on this, you might be tempted to conclude that birth spacing doesn't really have any impact on visits to a doctor for mental health issues for mothers once 5 months after birth. And you know, this is not just a noisy, non-significant result. These are quite precisely estimated around 0, right? It's a little bit noisier for the fathers, but in absolute terms, these are very small in any case. And yeah, the number of people in this category is also very small. So even if this was a real effect, it would A, be protective, and B, the population attributable fraction would be exceedingly small as well. So if we look at the results for physical health outcomes as well, it's slightly noisier, but it's so the blue shaped lines, the blue lines for the models without fixed effects again show this kind of I'll just call it that J-shaped curve, where short and long birth intervals associated with more visits to a doctor for physical health issues. But again, in absolute terms, even the largest differences are like 0.15 visits per year. And so the individual fixed effects largely wipes that out. The results for the period 6 to 11 months after birth, I'll spend less time on this one because I think it's broadly rather similar. So the models that we want to invest the most confidence in are those where we're using the individual fixed effects again. And again, largely all negative effects are wiped out. And even in absolute terms, even if you trusted the models without the fixed effects, in absolute terms, the differences are rather small from the reference category. And yes, I would draw largely the same conclusion from looking at the results for physical health outcomes too. So even if there is some kind of protective effect of longer birth intervals, you know, this is still, in absolute terms, that's a rather small number of visits, fewer visits to a doctor per year relative to the reference category. Okay, so let's look at the results for the period 10 to 11 years after birth. And yeah, overall, rather similar conclusions, I would say. So the scale is different here, of course, going up to, you know, from -2 up to 4. If we look at, so these are sibling-fixed effects analyses, and we remember this is not a causal effect. This is just a more effective control for family background factors, and it's also it's a little bit less precise in the way we define this birth interval length, right? Because we look at the mean birth interval across all your births, and so this could also be a combination of some very long ones and some very short ones, and you know, it's going to differ from person to person. So this is something we want to dig into in more detail, like looking at someone has maybe experienced any extremely short one, for instance. But overall, nevertheless, I would say that these results are in line with a null effect of birth spacing on mothers and fathers' parental health outcomes, even without sort of a perfect control. And in terms of looking at physical health outcomes, there's a bit more support for particularly short or particularly long intervals being associated with more visits to a doctor, maybe half a visit more per year if you have, for mothers, if they have extremely long birth intervals, like 10 years on average. So that's probably, yeah, that's probably a small number of childbirths. But yes, the overall, I think this is good news for parents, that perhaps they don't need to worry so much about birth spacing. So a summary of the results. On average, overall, I would say that the results from the associational analyses about the fixed effects do show some negative health outcomes for men and women, with particularly long or short birth intervals, but it's small in absolute terms, and most of those negative effects are wiped out in our fixed effects analyses. Overall, I would say that the results seem consistent with selection processes. The similar results for women and men, even in our associational analyses about fixed effects, suggest that stress might be driving part of that association that we see. Don't have to keep repeating this point, I guess, but I put it here to remind myself if I hadn't said it already. So don't get carried away with the sibling-fixed effect models. It should be seen as a better control for family background factors. We think the individual fixed effects is more powerful for controlling for these unobserved individual level factors. And it's also looking at outcome, immediately after the exposure, rather than 10 to 11 years later, where a lot can happen in the meantime, of course. I just want to put some caveats on the results that we present for the period 6 to 11 months after birth. If birth interval length is correlated with the probability of getting pregnant again, then it's possible that health could affect the subsequent pregnancy. The ongoing pregnancy could affect health. So this is pretty complicated. This is why we also did those analyses for the period 1 to 5 months after birth, where we think that this is far less likely to be a problem. And then we find quite similar results, right? Or at least qualitatively the same conclusion. So my final slide, do we capture health here or health-seeking behavior? Of course, we're looking at annual visits to a general practitioner, so it could be health-seeking behavior. But hopefully this is less of a concern in the individual fixed effects models, where we can hold all unobserved or observed individual individual characteristics constant, which might include also your sort of latent propensity to visit a doctor because of your anxiety about your health or so on. And just finally, be careful about generalizing these results beyond Norway. I think it might be reasonable to generalize these results to other high-income countries, particularly in the Nordic setting, where there's a similar welfare state and so on. And also be careful, but be careful about generalizing beyond that, I would say. And then also I would say it's important to be careful about generalizing to other outcomes like pregnancy complications, because we do look at a very particular health measure in this paper. So thank you for listening.